Thank you, respected chairpersons and BOS for inviting me here to give this talk. Now, consider this patient. This patient is a 70-year-old male. He's come to us with a lot of neck pain, with pain radiating into the left trapezius and the shoulder and arm. And neurologically, he's otherwise normal. On examination, what do you do with this patient? Straight away take him to examination, and we see that extension of this patient has got a lot of pain in the extension, and he's got a lot of pain on flexing onto the left side. So we got the MRI done for this patient, and if you see that he's come with the MRI, and this is what the MRI shows. Now, one would be tempted to start treating this as a cervical radiculopathy, maybe even offer surgery. You see there's a lot of foraminal compression in this patient. But on further, more detailed examination, we see that the patient actually has a restriction in his external rotations and internal rotations and abduction, and he was diagnosed to have a periarthritis of the shoulder joint. Now, this is a very common problem because what we see is almost 50% of patients who have shoulder pain have cervical pathology and vice versa. So it is very important to differentiate between these two conditions. Now, sometimes it is very easy, like in this patient where there was such restriction of motion, but when it is not so restricted, it becomes difficult to differentiate between the two. Why is this the case? This because a lot of your radiculopathy actually refers to the shoulder joint, and so they will come with shoulder pain when they actually have a C4, 5 or 6 radiculopathy. Even studies have shown that facet irritation and also cervical disc irritation causes pain radiating to the posterior part of the shoulder and the trapezius. C8 radiculopathy very often goes to the medial part of the scapula, and so the patient will come with pain in that region. Also, why these two conditions happen together very often is that as a person grows older, with the cervical degeneration, the patient starts going into kyphosis, and this actually changes the scapular alignment. The spino-scapular alignment starts going down, and so the spino-scapular movements also reduce. So a shoulder starts getting used much more, and because of overuse, the chances of causing injury to the shoulder are much more. So very often you get patients who have both these problems. So how do you differentiate between the two? Number one is that nocturnal pain. In your history, patients who have a lot of pain at night or while sleeping, they usually have a shoulder pathology. However, this is not a very specific condition. It could be different in different people. And then your pain which is radiating down distal to the elbow. This is very specific. If a patient comes with pain which is radiating below the elbow, distal to the elbow, then it is definitely a cervical pathology, and the shoulder pathology will not cause this. Then in a normal examination, you often check the power. The power may be reduced in shoulder pathologies also. In your biceps, flexors, etc. will be weaker. If it is a myelopathy, obviously it becomes very easy to differentiate between those two conditions, but the other problems are more difficult. So what is the next very important test? The one is your pain relief during abduction. We have our seniors here, Dr. SKS sir and Dr. Goregaonkar sir. This was a question in our Viva, which condition does the patient come with the hand on above the head? And one of the DDs was a cervical radiculopathy. So when the patient has got relief in symptoms with abduction here, so that indicates cervical radiculopathy. However, this is not as very sensitive. The patient may still have that without relief. The next is your Sperling's test and your arm squeeze test. Now, Sperling's test is when you extend the neck and cervical spine and do abduction, and then the patient complains of pain radiating from the neck into the shoulder and into the arm. That is quite a sensitive test, but it is not very specific again. The arm squeeze test is actually supposed to be the most sensitive and specific for it. So you squeeze the arm, and if the patient gets pain radiating into the hand, that actually indicates that it is a cervical radiculopathy and brachialgia, and thus it has got more than 90% sensitivity and specificity. So this is one thing which could help to differentiate between them. The next is your shoulder pathology test. The shoulder surgeons will be better to tell us, but if a person is able to, your drop arm test, if they are able to hold the arm when in abduction, it indicates that the chance of shoulder pathology is less. But if they are not able to hold it and it just falls down, this is a very specific test for a shoulder pathology. Now, if everything is equivocal, you're still not able to differentiate between the two problems, then what do? Then you can give a selective cervical transforaminal root block injection. Now, this again has got quite a specific, test for radiculopathy. However, it has got a little bit of complication risk because it can cause, you can end up injuring the vertebral arteries. But it is something which is useful, and if you do that, you can differentiate between these problems. And finally, also your shoulder injections, like you can give your subacromial blocks. If it is a bicipital tunnel, bicipital tendinitis which you are suspecting, give it in the bicipital tunnel. Even AC joint injections can be given to differentiate between the two. Again, these are not very specific. It is there are different studies in literature show that it could be ranges the specificity between 90% to less than 50% also. So there may still be an overlap. Finally, EMG and nerve conduction studies can also be performed, but again, they are very low in sensitivity and specificity. So in conclusion, the most important thing in differentiating between these two pathologies is your history and your physical examination. This is your most important thing. And along with that, of course, your special test and MRI are useful. But my advice is that in case you're not able to differentiate at all between them and it is quite confusing, it is better to conserve these patients and don't rush into any surgery. Thank you.